Pink eye is frustrating. It's one of the most common eye complaints, but it's often misdiagnosed or overtreated. And while many people associate pink eye with a viral infection, there can be other causes like bacteria or an allergy. In this video, we're going to break it down so you'll know what to look for, how to tell each apart, and what to do. Conjunctivitis begins with an insult, infectious or non-infectious, that triggers an inflammatory response which includes vasodilation leading to eye redness and enlarged conjunctival vessels, increased vascular permeability allowing immune cells and proteins to access conjunctival tissue to clear pathogens or to respond to allergens, and this can cause conjunctival swelling called chemosis and eyelid edema, fluid and cellular leakage resulting in watery discharge. And in bacterial conjunctivitis, this response is amplified by neutrophil-dominated inflammation, leading to the characteristic mucopurulent discharge. There are acute and chronic types of conjunctivitis, and in this video, we're going to focus on acute. And in viral and bacterial conjunctivitis, they share some similarities. They're both infectious, contagious, they can spread by direct contact, like person to person, or touching a contaminated object like a towel or sharing makeup. And they can start in one eye and spread to the other. Both can cause discharge, leading to the eyelids being stuck together, especially after sleeping. Let's break each down, starting with viral conjunctivitis. This is an infectious conjunctivitis caused by a virus, most commonly adenovirus, and it's the most common conjunctivitis in adults. It can spread by direct contact as well as airborne through respiratory droplets or reservoirs like swimming pools. Patients often report being around someone with similar symptoms or having recent upper respiratory infection symptoms, and it's highly contagious for about 10 to 14 days after the symptoms started, and also while the eye is tearing, so that can be a bit of time. Symptoms include redness, itchiness, irritation, foreign body sensation, tearing, blurry vision, mattering upon awakening, as if you have to pry the eye open, and there may be light sensitivity. And here's a clinical pearl. Symptoms can actually worsen before they get better. On exam, there's conjunctival injection leading to the classic red eye appearance, chemosis, conjunctival follicles, which are small, dome-shaped collections of lymphocytes, and they're especially seen on the lower eyelid in viral conjunctivitis. Punctate keratitis on the cornea, eyelid edema and erythema, and there may be small dry discharge on the lashes. A helpful exam clue is the presence of a painful preauricular lymph node. It's not always present in viral conjunctivitis, but when it is, and a patient presenting with an acute red itchy eye that is weeping and they just happen to sneeze in front of you, hopefully at a distance, that is like being given a cheat code. Epidemic keratoconjunctivitis, or EKC, is a more severe type of viral conjunctivitis, which can present with a membrane or pseudomembrane, subepithelial infiltrates, and photophobia. For treatment, like a common cold, viral conjunctivitis is self-limited, generally resolves on its own, but it can take a while, often 1 to 2 weeks or even up to 4 weeks. Because viral conjunctivitis is contagious, the two main treatment goals are number 1, manage symptoms, and number 2, minimize the spread. So for number 1, managing symptoms, what can help is using frequent cold compresses, frequent lubricating eye drops like over-the-counter preservative-free artificial tear eye drops. No prescriptions are needed, and that includes antibiotics because viral conjunctivitis is due to a virus. An exception is a patient with EKC who has subepithelial infiltrates or a conjunctival membrane. This may require further treatment like a topical steroid, which is recommended to be prescribed by an ophthalmologist. For minimizing the spread, it's helpful to follow these measures until symptoms have completely resolved. So frequent hand washing, avoid sharing items like towels, makeup, etc. Avoid contact with your own eyes, avoid swimming, and consider isolating a patient who you suspect might have viral conjunctivitis in your clinic or the ED to help minimize the spread. Generally recommended to stay home from work or school until the patient is symptom-free and the eyes are no longer red or weeping. Now, this can vary for people, and seeing a local eye doctor can help provide specific guidance depending on the presentation. An example treatment regimen is listed here. An interesting treatment option is 5% povidone iodine or betadine. So, betadine is often used in eye and eyelid surgeries as an antiseptic. It's been reported that instilling a drop of 5% povidone iodine onto the affected eye with viral conjunctivitis has the potential to reduce viral load and possibly decrease symptoms. But it is important to note that it is not an FDA approved treatment for viral conjunctivitis. Betadine does lead to eye stinging, so what can help is numbing the eye first with a numbing eye drop like proparacaine or tetracaine, then instilling the povidone iodine, and afterwards rinsing the betadine off the eye. So, a quick recap, make sure you're still with me. Viral conjunctivitis, watery, itchy, conjunctival follicles, especially on the lower eyelid, painful preauricular lymph node. That's that cheat code. Often starts in one eye, spreads to the other, very contagious. In treatment, supportive care. It takes time to go away. Let's move on to bacterial conjunctivitis, which is another type of infectious conjunctivitis. It's commonly due to Staphylococcus aureus, Streptococcus pneumoniae, and Haemophilus influenzae. Say that 3 times fast. It's more common in kids. It can spread by direct contact, airborne, and through sexual contact, like in Neisseria gonorrhea. Some risk factors include dry eye, blepharitis, recent ocular surgery, exposed sutures, or foreign body. It's contagious while the eye is tearing and discharge is present, which can be for days, but it's been reported that people are no longer contagious after about 24 hours after starting a topical antibiotic. Symptoms include eye redness, irritation, tearing, burning, light sensitivity, blurry vision, and mattering upon awakening. Now, a symptom I did not mention is itchiness, which is not typical in bacterial conjunctivitis. So that's a key differentiator from viral, and as we'll talk about soon, allergic conjunctivitis. Common exam findings include conjunctival injection leading to redness, conjunctival papillae, which are cobblestone-shaped bumps with a visible central vascular core, so that's different than a follicle, mucopurulent or watery discharge, but classically pus, chemosis, lid erythema, and conjunctival membranes. For treatment, because it's contagious, just like in viral conjunctivitis, it is also important to practice proper hygiene and hand washing in bacterial conjunctivitis, which we should do anyways. Most cases of acute bacterial conjunctivitis go away on their own, generally within 10 days without treatment. But topical antibiotics like an eye drop or ointment can help shorten that time frame. Antibiotics have been shown to speed up recovery by decreasing the duration of symptoms and eradicating the bacteria, which can help patients get back to their normal activities sooner and reduce the risk of spreading the infection. It's been reported that a topical antibiotic is helpful when it's started within the first 2 to 5 days from symptom onset. There is still a reported benefit during the 6 to 10 day time frame, but it's reduced. Example topical antibiotics are listed on the screen. So in addition to minimizing the spread, using a topical antibiotic when indicated, it's also helpful to use frequent cold compresses and frequent over-the-counter lubricating eye drops. So we just talked about the treatment for acute bacterial conjunctivitis, but an important distinction is this is different than chronic and hyperacute forms of bacterial conjunctivitis like in chlamydia and Neisseria, because those, they do require treatment and they need to be seen by an ophthalmologist as soon as possible. If you want to find out more, let me know in the comment section and maybe I'll be able to add it to the Red IMD playlist. So let's do a quick recap. If you got some water by you, go ahead and take a sip, keep that brain fresh, keep yourself hydrated. So we just reviewed bacterial conjunctivitis, mucopurulent discharge, contagious, no preauricular lymph node, except in gonococcal conjunctivitis, and no itchiness, supportive care, prevent the spread, topical antibiotic. Viral conjunctivitis, watery, itchy, follicles, painful preauricular lymph node, contagious, supportive care, takes time. Let's move on to allergic conjunctivitis. This is a type of non-infectious conjunctivitis that occurs in response to an allergen, and there are many different types. But in this video, we're going to focus on seasonal, which occurs in response to an airborne allergen like pollen, and perennial, which is year-round like dust mites or perfume. Seasonal and perennial allergic conjunctivitis is a type 1 hypersensitivity reaction mediated by IgE antibodies. Upon re-exposure to an allergen, IgE antibodies bound to conjunctival mast cells triggers mast cell degranulation, releasing inflammatory mediators like histamine in the early phase. This leads to itching, vasodilation, and increased vascular permeability, causing redness, swelling, swelling, and tearing. In the late phase, eosinophils and other inflammatory cells are recruited, contributing to prolonged inflammation. There often is a history of other allergic conditions like asthma, eczema, or hay fever. And this is key. It is not contagious. The symptom onset can be pretty rapid after exposure to the allergen, and the hallmark symptom is severe itching, often worse than in viral conjunctivitis. Other symptoms include eye redness, tearing, irritation, foreign body sensation, pain, and eyelid swelling. There can also be blurry vision, but it's usually mild unless it's a severe case. And there may be light sensitivity like in vernal keratoconjunctivitis. Exam findings include, you guessed it, conjunctival injection leading to a red eye. Also, conjunctival papillae, especially on the upper eyelid. And the papillae can be more prominent than in bacterial conjunctivitis. There may be chemosis, eyelid edema, and unique to allergic conjunctivitis is an allergic shiner. This is where the eyelids can appear dark, as if they're bruised, but there's no history of trauma. Also, eyelid dermatitis. The eyelids can be thick, kind of scaly, dried skin, very itchy. What you generally do not see on exam is a preauricular lymph node, again viral, or thick mucopurulent discharge, bacterial. For treatment, just like in viral and bacterial conjunctivitis, allergic conjunctivitis is often self-limited, but in severe cases, further treatment may be needed. But in general, avoid the allergen, use frequent cold compresses, and frequent lubricating eye drops. The lubricating drops can help to provide symptom relief and may help to wash away the allergens. And sometimes this is all that's needed, especially in milder cases. But as mentioned, the hallmark symptom is itchiness. So what can help is adding an anti-allergy eye drop. I generally recommend a combination eye drop because it brings a 1-2 punch. It has an antihistamine which provides a fast onset of symptom relief. It helps to address the current problem. It also has a mast cell stabilizer which helps to prevent mast cells from releasing more histamine. So it's used to try to prevent a future problem. So you get a short-term and a long-term benefit. I like it. And an example is olopatadine. Depending on the presentation, you can also consider an oral antihistamine. Here's an example treatment regimen. Allergic conjunctivitis typically improves within a few hours to days of avoiding the allergen and starting treatment, but sometimes it can last longer if exposure continues. I like to keep things simple, and this may help when you're seeing conjunctivitis, especially if you're not quite sure which type it is. Although the causative agents differ, and there are similarities in the treatment. So in all three types, at the minimum, this can be your foundation. Number one, avoid the problem. Yes, it's easier said than done sometimes, but if you know someone has an itchy red eye, politely keep your distance. 2, frequent cold compresses. An example is at least 4 times a day for 10 minutes at a time. And 3, frequent over-the-counter, preservative-free, artificial tear eye drops, QID plus. So at least 4 times a day, depending on the symptoms and severity, patients can increase the use. And then you can add from there depending on the case and severity, whether or not the patient needs a topical antibiotic. In bacterial conjunctivitis, do they need an anti-allergy medication? And remind patients, no contact lens wear, avoid eye rubbing, and avoid redness reliever eye drops. Conjunctivitis is very common, but sometimes patients can present with what appears to be conjunctivitis, but it could be something else. So here are some red flags to watch out for. Pain. And I'm not talking about the discomfort or irritation, significant photophobia, decreased vision. Patients with conjunctivitis can definitely have blurry vision, and sometimes that improves with blinking multiple times in a row or cleaning up the discharge so it's not blocking their visual access. But significant vision decline, that could be from something else. Contact lens wear, that alone increases the risk for infections and other complications. Severe purulent discharge with a rapid onset or corneal haze. So these could be clues of other eye conditions like keratitis, uveitis, or gonococcal conjunctivitis, and an ophthalmology consult is recommended as soon as possible. When should a patient follow up? I generally recommend that all patients with conjunctivitis see an eye doctor to make sure there's nothing more serious going on and that the patient is improving as expected. Now, if it's a mild case, there's nothing urgent going on, at least have a scheduled eye appointment just in case. It's better to err on the side of caution. And of course, if there's any urgent concerns, try to get them to be seen as soon as possible or consult ophthalmology. The specific follow-up is determined case by case, but here's a general guide. For mild, acute viral or allergic conjunctivitis, follow up within 7 days if it's not resolved. For non-gonococcal bacterial conjunctivitis, you may see some variability on this, but I generally recommend a little sooner, so within 1 to 5 days, depending on the severity. That can help determine whether a topical antibiotic is needed and to make sure that there's no corneal involvement. What about a same-day eye exam or an urgent ophthalmology referral? Some examples include gonococcal bacterial conjunctivitis, pain, photophobia, vision loss, rapidly worsening symptoms, concern for corneal involvement, or orbital cellulitis. A quick comment about contact lens wear. So these patients are at higher risk for complications. If it's a mild case, there's no signs of corneal involvement, there's no urgent concerns, and no changes to vision. Tell the patient to stop wearing contact lenses, do not resume until the symptoms completely resolve or they're cleared by an eye doctor. And in bacterial conjunctivitis, fluoroquinolone eye drop like moxifloxacin is recommended to cover for pseudomonas, an outpatient follow-up within 24 to 48 hours. But if there is concern for corneal involvement or the exam is concerning, especially vision changes, a lot of pain, same day or at least call an ophthalmologist and review the case with them. And here's a tip. If you're going to call ophthalmology, take a few pictures. That can be really helpful for the ophthalmologist on call to review. So here we go. Viral conjunctivitis, watery, itchy eye, follicles on the lower lid, painful preauricular lymph node, that's the cheat code, contagious, supportive care takes time. Bacterial conjunctivitis, mucopurulent discharge, mild papillae, no preauricular lymph node except in gonococcal conjunctivitis, and contagious, often topical antibiotic. Allergic conjunctivitis, rapid onset, bilateral, papillae, no preauricular lymph node, hallmark symptom, itchiness, eyelid dermatitis, not contagious, supportive care, get away from the allergen.